Welcome, everyone, to the first of our 3 sessions on artificial intelligence in health professions education. I am Carol Tucker. I'm currently the Associate Dean of Research at the University of Texas Medical Branch, and my introduction to AI started back in the 1980s when I was doing engineering school and had to write in Lisp and cars and cutters for those that are old enough to remember that. I've had the privilege of chairing the workshop planning committee group of incredibly bright, intelligent, thoughtful individuals about AI in healthcare education, and also worked on organizing the workshop. I want to thank the members of the IHP Forum for choosing this topic and for its financial support. Today, this first session is what we're calling a pre-workshop because it's where we discuss what AI is and ask the question why. Why is it necessary for us as health professionals and educators to understand the role of AI across all the health professions? We'll hear different responses to that question today, but in a nutshell, it is because AI is already here and AI is here to stay. As consumers, as patients, as providers, and as educators, AI is already embedded in our everyday lives. So it is our responsibility to understand what it is. And while we hear a lot about the peril of AI, there is also huge potential for AI improving our work and decreasing stress if it's done correctly. Today, we will hear from colleagues in the health professions describe their experiences with AI. We, as the workshop committee, felt that it would be important for educators to hear how AI is used in practice to stimulate thinking about what is needed in education to prepare learners for using AI in the healthcare environment. As the session progresses, we encourage the audience to use the chat or question answer function to ask questions and to make comments. And while I will do brief introductions, please refer to the speakers' bios for a complete description of their backgrounds. So now to open the workshop, we will hear from Dr. Cornelius James, who is a clinical assistant professor in the departments of internal medicine, pediatrics, and learning health sciences at the University of Michigan. Dr. James was a 2021 American Medical Association Health System Science Scholar and one of 10 inaugural 2021 National Academy of Medicine Scholars in Diagnostic Excellence. As an NAM scholar, he began working on the Data Augmented Technology Assisted Medical Decision Making, or Data MD curriculum. The Data MD curriculum is designed to teach healthcare professionals to use AI and machine learning in their diagnostic decision making. Dr. James is also leading the Data MD team as they develop web-based AI ML curriculum for the AMA. Dr. James will help us understand AI applications using an example that many of us can relate to, that involving patients' risk of falling. After Dr. James, I will offer some remarks wearing my data scientist hat before we turn to our other two panelists, who will each provide unique perspectives related to AI, one as a clinical informatics nurse and the other as a psychologist. Following the panelists, we will have brief reflections from two learners on what they heard from their unique perspectives within their education and healthcare systems. We will finish this session today with the planning committee members providing questions and comments on the topics discussed or topics that should have been discussed. Again, I encourage everyone to use the chat or question and answer function to share your thoughts and questions as the speakers are presenting. The planning committee is monitoring the chat. With that, I will ask Dr. James to turn on his camera. We see him already. Unmute and the floor is yours.
Thank you very much for that introduction, Dr. Tucker, and just wanted to state that I'm very excited about the opportunity to speak with our audience this morning about this very important and rapidly evolving topic. So I will proceed with sharing my slides now, and I do not have any disclosures. As far as objectives go, I'm hoping that by the end of this talk, you'll be able to define artificial intelligence and machine learning, that you'll also be able to summarize the current state of AI and ML in clinical practice, and also describe the current state of AI and ML in health professions education. In addition, I would like to encourage us to, or provoke us to, some thought and dialogue related to this fast-moving field. So imagine that you are caring for Mr. Harris, a 73-year-old man with a recent history of Alzheimer's dementia or recent diagnosis of Alzheimer's dementia. And Mr. Harris is presenting to the office for a health maintenance examination, or a physical as it's often called. He's accompanied by his son, Adam, who is concerned about his father's risk of falling. But Mr. Harris insists that a prior fall wasn't due to any issue other than maybe walking too fast, multitasking, or old shoes. So upon further discussion, Mr. Harris does agree to activate, with the assistance of his son, Adam, an artificial intelligence-based application that uses sensors in his smartwatch to assess a person's fall of risk, or more specifically, his risk of falling. And over the course of about a month, the monitoring reveals multiple loss of balance events. And the algorithm describes Mr. Harris's risk of fall as high risk. And this information is subsequently integrated into his electronic health record. So, given your role, and I understand that there are many of us out there with various roles within the health professions, but given your specific role, how would this information related to Mr. Harris's fall risk, how would that impact or inform your interactions with Mr. Harris? I would like to think that each of us, regardless of what health profession that we are in, that this information that could potentially impact our interactions with a patient like Mr. Harris. So how did we get here? We have smartphones, we have smart cars, appliances, watches, televisions, and much more. And many of these devices that we're currently using today produce large amounts of structured and unstructured data. The growth of big data is an important reason for why we're having this conversation today. We use the term big data not only because of the amount of data produced, but also because of how rapidly this data is being produced and the different types of data being produced. But data by itself isn't of much value. Instead, it's most useful when the data has been processed and interpreted. The explosion of big data, coupled with powerful and more readily available computers capable of processing large amounts of data, has led to increased activity in artificial intelligence. For example, in a matter of minutes, I can sift between multiple applications that employ artificial intelligence on my cell phone or tablet. For example, I can move or transition from getting directions to identifying movies or television shows that I may want to watch based upon my prior viewing history. I could also receive recommendations related to books based upon searches that I previously performed in Amazon. Even my email uses machine learning methods to separate emails by level of importance. So AI is everywhere. So what is AI? AI has been around for decades. It's an umbrella term, and it involves the use of computers to perform tasks that typically require objective reasoning and understanding. There are many domains of artificial intelligence. For example, machine learning is an application of AI that has had significant breakthroughs recently. Machine learning involves using computers, or computers using complex computational or mathematical methods to find patterns in large data sets. And identification of these patterns results in classification or a prediction. Deep learning models are called deep because they have many layers of information and connections of artificial neurons that are drawn between features at each level of a model. While these models can be very helpful in making complex predictions, some have understandably raised concerns about not knowing what led to a model's prediction, or not being able to see inside the quote black box. This is especially concerning for some when it involves when the deep learning model is used for the care of patients. Computer vision and natural language processing are other branches of artificial intelligence. The domain of natural language processing is focused on AI understanding, interpreting, processing, and manipulating written and spoken language. Many of us are familiar with conversational agents like Alexa, and Siri that use natural language processing techniques. ChatGPT from OpenAI also employs natural language processing methods. Healthcare has also experienced a data explosion or data deluge, as some call it. This has led to rapid proliferation of artificial intelligence and machine learning models in healthcare. With the enormous amount of patient data available, there's much more to consider when we're making clinical decisions now. The amount of health related data will only continue to increase, especially as more patients begin wearing or using wearable devices. As indicated in this figure or by this graph, the number of facts affecting patient care decisions far exceed our cognitive capacity. So what are we to do? Where can we get some help? There's been a proliferation of AI-based applications and devices in healthcare. We're seeing devices that accurately and autonomously diagnose diabetic retinopathy, that aid diagnosis of abnormal heart rhythms and heart failure. They diagnose falls and or fall risk, and others that can effectively serve as digital therapists. In addition, the number of FDA-approved devices has significantly improved over the past decade. Recently, the FDA approved its 500th AI-based device. However, healthcare has lagged behind other fields when it comes to application of AI. There are certainly important challenges and reasons why there's been that lag relative to other fields. It's going to be important for us to consider these challenges as we look to implement AI-based technologies into healthcare. So certainly there's the potential for bias and perpetuation of inequality or inequities and disparities. That concern is certainly real. Colleagues and I have also outlined or described other potential challenges in a recent NAM perspective. These challenges include issues related to governance and regulation, trust and transparency, data quality, availability, infrastructure, and the impact that these technologies could potentially have on workflow, and the issue of calibration drift. Each of these can be grouped under one of 4 overarching categories that include clinicians having a reason to use, a means to use, a method to use, and a desire to use artificial intelligence. So, how does this proliferation of AI in healthcare impact medical education? The biomedical model is the predominant model for educating physicians, and it's likely that this model was popularized by the 1910 Flexner Report, which established this model as the gold standard for medical training specifically. Clearly, times have changed since the Flexner Report. With the proliferation of AI-based healthcare technologies, we must transition to a biotechnical model for educating physicians and healthcare professionals. This model goes beyond the human biologic system to understand normal and abnormal function to provide a basis for preventative or therapeutic intervention in human disease, but it also considers the impact that intelligent technologies will have in the preventative, diagnostic, therapeutic interventions in human disease. So this is that biotechnical model that I propose we begin considering. So currently AI has minimal presence in medical education curricula. Currently education is mostly in the form of non-mandatory offerings like electives, online courses, workshops, programs, and interest groups, but this isn't going to be conducive to preparing our learners to effectively engage with AI. It could potentially be overwhelming to think about creating a new course or instruction in AI and fitting it into a curriculum. But I anticipate that over the next 1 to 2 years or so, we'll see this content firmly integrated or embedded into curricula like health system science curricula, clinical reasoning, clinical skills curricula, and evidence-based medicine curricula. And in medical education, many of us are familiar with what are often referred to as the 3 pillars of medical education: clinical science, basic science, and health system science. I expect that over the next 5 to 10 years, AI will actually become a foundation for the pillars in medical education, as it'll transform the way we teach, assess, and apply information in these domains. We'll need to rethink and reconsider what clinicians do and what clinicians will do and what AI will do. what task, be it clinical or educational, will be delegated to clinicians versus artificial intelligence. In a recent paper, we described AI as a fundamental tool set of medicine. And I think it's important for us to note the difference between viewing AI as simply a tool versus having the ability to interact with, engage with, and team with AI. This is going to be the tool set that clinicians of the future will require. To this end, the Data Augmented Technology Assisted Medical Decision Making team, or Data MD team, is working on curricula designed to teach learners across the continuum of medical education about AI. Our mission is to develop, implement, and disseminate innovative healthcare AI ML curricula that serve as a foundation for educators to develop curricula specific to their own institutions and/or specialties. And to accomplish this mission, we've assembled an incredible team of clinicians, data scientists, lawyers, researchers, medical educators, and administrators to ensure that we are considering all perspectives when it comes to developing and implementing these curricula. We're using an evidence-based medicine foundation as we develop an online curriculum that will be, again, designed to teach learners about how to use AI and ML, specifically in this case, in the diagnostic process. We're working with our Center for Academic Innovation to ensure that this curriculum is launched in June of 2023. We'll also be studying the effectiveness in this curriculum across the continuum of medical education. Our team is also working with the AMA to develop a curriculum designed to take a deeper dive into some of the issues or topics in artificial intelligence and machine learning in healthcare, and we're anticipating launch of this curriculum in late 2023. So a few take-home points. As Carol mentioned, artificial intelligence and machine learning in healthcare is here, and it'll only continue to march forward. AI has the potential to transform the delivery of healthcare. Currently, AI and ML instructions in health professions education is lacking, and we must begin to consider how we incorporate this content into curricula. And finally, health professionals must be vocal stakeholders in the development, deployment, and the education when it comes to use of AI and ML-based technologies in healthcare. Thank you.
Thank you, Dr. James. What a great talk. What a great setup for us to really think about some of the issues. Really appreciate that. We have a few questions coming up in the chat, and I'm going to categorize these as maybe as a data-driven a little bit in use of it. And so the sandbox for AI in healthcare, the current status, what we're seeing current AI technologies being developed on, are often federated or developed by groups that the data may be uneven in terms of what it represents. So if AI, the technology advancement, is driven by profit in many of these companies. And I know we as a healthcare system have been approached about, if you let us into your EHR sandbox, we'll come up with all of these things for you. We want access to the data. Can you talk a little bit about how do we embed preventative medicine in there when the data set may be biased, or the tools that people are using may have a bias in there? So not the technology, but kind of the application. Big question.
Yeah, it's okay. So I just want to ensure that I understand the question. So given the data that we currently have available, how is it that we use the models that are being developed using that data for preventative measures, or to prevent
versus catastrophic medicine? So if the farm companies, I'm using this as an example, if a lot of the technology and the advances in AI are driven by companies that may have other interests other than solely patient outcomes, how do you balance that, or how do you address that in the curriculum?
I see. Okay, thank you very much for that
It's
question.
my fault. Yeah.
No, it's okay. So, I really do believe that this is where that interdisciplinary team comes into play, and this is where It's going to be very important for us to ensure that we have multiple stakeholders, at the table, not only when it comes to development of these models that will potentially be deployed in healthcare, but also when it comes to the evaluation of these models to ensure that when they are deployed, knowing that there are different or varying agendas and or motives or interests, it's going to be important that we ensure that we have unbiased individuals and or various stakeholders that are at the table to ensure that the models that are being deployed are truly accomplishing the goals that we would like them to accomplish. And then when it comes to education, ensuring that our learners are able to kind of take into account or be aware of the potential bias associated with development of models by specific groups or individuals. I see it as being very similar to when we're reviewing a randomized controlled trial and we see that there was the potential or that industry developed that or was studying their specific product. It's not as though we say we can't believe this product or believe that it's going to be, or that this intervention is going to be helpful. It's more so just kind of looking at it, understanding that there is the potential for bias there, given that that study was done or completed by someone from industry. And I look at it as being very similar when it comes to medical education or health professions education, ensuring that our learners are trained to have that kind of eye for potential sources of bias when it comes to the models that'll be deployed in clinical practice, that'll be deployed in clinical practice.
Great answer. Thank you. I'm going to actually do a very short presentation that augments Dr. James's, in large part given my role as a data scientist. So I really come at this from an engineering perspective. I am a physical therapist by training as well. So I have a little bit of a blend of perspectives in this. So hopefully we'll be able to see that. Um, I'm going to move my windows for a second. Sorry. I can see you guys can see the share button at the top. Okay. So when I think about data sharing, oh, hang on a second. So when I think about data science and AI, I really take this from an information science approach where I look at everything we know kind of as data that's then moved into information through a variety of processes, by which then the information that we gain from the data, so the sorted data, we gather knowledge from, and knowledge often comes from applying different algorithms or analytics where we really start to see the patterns in it. Down below the diagram that kind of shows the stacking from data to information to knowledge is actually data from our long COVID study here at UTMB, where to the left you can see kind of the mess of actually what's information. There are colored dots which represent data that then have edges and graph connections made. And that at the end, when we sort this out, and again, this was done by using AI, we start to see patterns within the data that form. Large data analytics is certainly an evolving field, and Dr. James has chatted a good bit about that. We beginning look at data discovery, and those data sets and the type of information we need from those are a bit different. When we move into data science, again, data science can be done on any size of data set, but typically there's a complexity in the analysis. And when we combine those, or we really look at big data, and as Dr. James said, the explosion of computational power, of data sharing, of access to data, of extraction of data from electronic medical health records or micro data we see in wearable sensors has really moved this field forward very fast. In healthcare, there's a lot of organizations that contribute to our big data, everywhere from payers to government agencies to patient portals, smartphones, pharmacy systems, wearable devices, and we're really experiencing a dramatic expansion in how data is being used and how we generate that knowledge. Again, data exists, but data by itself, without being sorted, without having relevance applied, is just data. It's that knowledge that we want, the information, and then experts looking at it, looking at the patterns and coming up with knowledge. If you notice, I did leave out the top of that pyramid, which is called wisdom. And wisdom often is within the context of how that knowledge is used. And the previous conversation at the end of Dr. James's, where we talked a little bit about, well, how do you know how that is being applied, or if the data only shows the bad part of health, how do we know we're really getting the right wisdom out of it? And sometimes that wisdom with AI depends on who the lens is of the person using the tool. And I think that's where some of the fear comes when people confuse that AI is scary. It's not the technology that's scary, it's the fact that we really need to think about where is the wisdom that's being generated and who's doing that. There's a textbook, The Future in Deep Medicine, that if people haven't read it, may be one access point to start thinking about this. But that we really are going to harness big data, the concepts of precision medicine at the public health or just massive population level is really coming to bear. Big data and AI is really not the issue, and in some ways, it's also not the answer. The new information being generated by AI builds on prior information. So, whatever AI system and knowledge you use now is probably from data that was generated in a large enough quantity for decisions to be made on. One of the issues that faced us within healthcare and using AI was that a lot of the large healthcare data sets really have a focus on syndemics. So, those aspects of health that are disease promoting. And so, if you're looking for what are those salutogenic effects of health or trying to use AI to get a better balance idea of health, the data sets we're operating on often only document the disease aspects. Hopefully, with wearable sensors and some initiatives through the national government, we'll start to see a building of more balanced data sets that may provide different answers. There is no such thing as raw data in science. All data, and actually the knowledge that we get out of the data and information, has to have some theory behind it to illuminate the data. Dr. James pointed out that if you don't have good data, you're not necessarily going to have good product from it. And I think as we look at the connections between it and what I may intuit as somebody that has a theoretical framing of health may look very different from an AI that's just operating on grouping and organizing the data. So, in short, big data. And from that perspective, our AI and ML applications have to really be driven by what's important in the data for us to gain that knowledge and wisdom. So, what are the features of the data? What are the analytical techniques? Are we looking at connections or are we looking at statistical differences? And there are different types of AI tools that look at both of those or use those. I just wanted to again come back to this fact that well, it's not really a fact. People have proposed that the inherently flawed healthcare system may move us away, or does it move us closer to new paradigms in rehab practice and research? And I just put up a quick little visual of what we actually are talking about in some of the AI and ML. And if you look at that middle row, we talk about a supervised learning, which is where the data set we know what's right or what's wrong or what where the patterns are, and we're just doing a mapping to get it efficient. Unsupervised learning is really data without labels, and that's just really throwing everything kind of in the pot and looking at the connections between it. And when we talk about training and testing and AI generating, we start to think of this unsupervised learning, which is a little bit harder sometimes to understand what's in that black box. Where are the theoretical considerations? Can there be theoretical considerations when we're dealing with such a massive data set? And then reinforcement learning is often what we see when we look at autonomous humanoid or robots. And so again, just as you start to dig in AI, the data matters, the approach you pick to parse through the data, the features you use all make a difference in how we embed in our healthcare education for individuals to start thinking about all of the different pieces interacting is a task. And I commend Dr. James in the University of Michigan for starting that. Generative AI, and this just recently, as we all know, has really emerged on the field. And people have suggested that the apprehension of using generative AI and generative AI tools is related to who is the developer and what is perceived as the motivation of the developer rather than the AI technology or tools and applications themselves. And my viewpoint on really thinking about AI is that if we are not just passive learners about AI, but we need to be active participants in really guiding the use of AI within the policies and systems. And so I applaud and I'm really excited to see this being included in all of our curriculums across the health professions. Potential resources, and I just wanted to mention those. There's a big data to knowledge program at NIH BD2K that may have some information for people at some of the smaller sites that are dabbling in it. The Bridge to Artificial Intelligence is a fairly recent effort. And again, there are large data sets and techniques and do a lot of webinars in there. And then finally, AMIA also has some things. So just a few resources as everybody thinks between this pre-workshop and our next workshop in 2 weeks about where to go with that. And then I finally just want to say thank you, but I wanted to share as I was driving into work today, a colleague of mine shared with me this text. And this text was generated by a teenager. And if you look at the top, you can see, sorry, I should have turned that off. It says, Dear Mom in square brackets. And it was a teenage set of boys that hadn't emptied the cat litter box or the dishwasher. And so instead of writing their own note, which they tried, they went to ChatGPT and asked them to write an apology letter to their mom. So I just thought that as we talk about what AI can do, it has a lot of uses and it's certainly out there. And thinking about the ethics and the values and learning to think after ChatGPT becomes an issue. So I'm going to stop there and see where we're at. How are people doing? Any questions? All right. Well, then in that case, I am really super delighted to move on to our next set of speakers. So, sorry. So we'll now be hearing from two distinguished health professionals who work in the world of artificial intelligence as well. So we're going to hear from Dr. Kelly Aldrich, who is a board certified informatics nurse specialist, served for over 35 years in clinical, academic, and leadership roles. Dr. Aldrich will speak to us about the topic of interoperability for effective AI. She will then be followed by Dr. Edward Bungie, who is the Associate Chair in the Psychology Department at Palo Alto University. So Dr. Aldrich, we see you. Thank you for turning your camera on, and the floor is yours.
Thank you so much for having me. I really appreciate the opportunity, and the previous two presentations will really set up my talk. So I think that we did an excellent job in timing. Again, real pleasure to be here, and thank you for having me. So for today, I do want to talk about interoperability. And my objectives are to discuss the importance of data interoperability for evolving AI and machine learning models, and to explore trends advancing multidisciplinary healthcare in both simulation and virtual environments that are using AI and ML. So where do we start? The definition of interoperability most oftentimes depends on the lens that you look through to see where does interoperability create the most useful patterns of data. And if you were to turn to 21st century cures, They have defined interoperability as health IT, enabling secure exchange of information. I think what I like most as a previous practicing clinician, critical care, and then moving into informatics is that they point out how IT, without special efforts on the part of the user, should be allowed to have complete access to data. This is what we run into challenges with. So if you ask a clinician, their definitions would be plug and play interoperability for healthcare. They just need to have access to the data and be able to use it for their patients. Kind of much like a Legos. We know that we could put any set of Legos together and they just work. This is not necessarily the same in healthcare. And so this is a great analogy of how clinicians' lenses, and as we educate, we need to be respectful and understand getting to the root of the issues of interoperability. Again, as clinicians view it, things should just work together. As an informatician, we look for useful data. So as previously spoken to, how do we get to the data? How do we create information, knowledge, and then wisdom? In healthcare, we're talking about how can we do this to improve the patient's outcome and improve the impact that we have in care coordination. We cannot do that without a model. And so Dr. Bill Stead and the Center for Medical Interoperability did publish this in the NAM Procuring Interoperability, but I present this model on behalf of them because it is the most inclusive and one that you should be referencing, that in order to have interoperability, we need to make our way completely around the spoke. We have to look at infrastructure, so the security, cybersecurity. Is there someone hacking or creating issues within our data? We have to be sure to look at the infrastructure. We have to be able to ensure in the maturity model the syntactic and the semantic ability to be able to share and stack data to get from data to information and knowledge. And most importantly, for clinicians in patient care coordination, they look to the orchestration and the contextual dynamic interoperability, which frankly oftentimes are the ones that the pieces of the interoperability models that are often left out. So if you ask a clinician, this is what they want. They want to be like the fighter pilots where they can actually see data that's organized and presented to them, sometimes raw data, sometimes data models that stack on one another so that they can actually make informed decisions to best care for their patients. But what we have is a scenario like this. This is a typical ICU that we would see many different screens, many different, so there's 13 different screens here and machines that are life-sustaining to this patient. And you might not be able to see the patient in the middle of this, but when I was a trauma and open heart recovery intensive care nurse, I worked in this environment for decades, and I was the interoperability within this picture. These screens are not being fed into the electronic medical records as we would hope, so that we can organize and have stacked models of care to make great decisions for our patients. So frankly, our patients and care teams deserve better. The lack of comprehensive interoperability and data liquidity can compromise patient safety and undermine care quality and outcomes. It definitely contributes to clinician fatigue, which should be at the top of all of our agendas, and it wastes billions of dollars a year. And the lack of total interoperability, as you see here, is because they have the medical devices around the patients are proprietary data. They do not speak to one another in most cases in a scalable and highly reliable model. So we look to, as clinicians, how do we model that patient data? As Dr. James spoke about, how do we use all of the sensors and all of the data available to us to actually have an impact that's unbiased and equitable for all of our patients? We do also have to consider cybersecurity vulnerabilities. When each proprietary medical device that sits amongst itself, how do we know that that perhaps hasn't been hacked or someone hasn't gone in and changed the model that could affect, in fact, how we care for the patients, and having significant impact if this were ventilator data, maybe a heart-lung machine data. This could be extremely important to know. So as clinicians, we look for useful and actionable information that comes from the data to help with our care coordination. So clinical interoperability should never be an afterthought. This is something that as educators, we should ensure that we have useful, safe, and satisfying data that's available. So I always go back to, this is not a failure of resilience, as sometimes it is often spoken about. In the real world, talking to clinicians, they are very tired. They need our help in using data to coordinate care. We have to look at the crossing the quality chasm. This is my favorite reference that I use in all of my advanced concepts informatics courses, both at the doctoral and master's level, where we talk about poor designs set the workforce up for failure, regardless of how hard they try. We really have to move beyond this model and leverage these AI opportunities, much like other industries. So we look at other industries, they would never dream of building a building without creating a digital twin and mapping the system, much like we should be doing is mapping the care system. Do we want to add a new device into the coordination of care? Do we want to add a new device into caring for the patients? We should be mapping this out in a digital twin and see that both the positive and the negative impacts that it has. Much like we did here at the center in this code blue scenario, we looked at noise, we looked at chest compressions. How is this stacking up to the algorithms of what we should be doing during a resuscitation effort? All of these data points are extremely important that we consider true interoperability and data liquidity. So if not, we're going to have working as designed without a design. As you can see, the air traffic control, very clean information is presented to that person to make sure that our flights don't crash into one another. But on the right-hand side, this is a picture that I actually took of an operating room where you can see the technology was pushed out of the way and they continue with their manual processes because what they have in coordinating the data into information and knowledge does not create wisdom, and they have to use dry erasers and markers and sticky magnets to actually coordinate care. We cannot get away from the facts that these are what our clinicians are facing, and we should be taking this head on to help redesign the systems of care. So where are we headed? We at Vanderbilt University School of Nursing, we're looking at prescribing technology. So how can we actually immerse our clinicians in virtual reality for empathy training, as well as knowing what their patients are dealing with? So this is one example. We also know that there are many implementation models across the US that are trying to address the staffing issues. We have to pay attention to things like this company that's looking at ambient intelligence. On the left-hand side, you see the patient attempting to get out of bed, which would contribute to your falls and potential negative outcomes. And on the right-hand side would be what I spoke to about with the digital twinning, where you can actually see and predict that the patient would be getting up and then be able to reach them in time before, in fact, they fall. So as I wrap up, I see some trends and additional discussion, which we should be including is the complexity of systems design thinking. We have to consider the socio-technical models from Siddig and Singh and the learning health system. How do we test these models, use them for useful information to improve patient safety and quality and equity of care around the people, process, and technology paradigm? So thank you very much. And Dr. Tucker, I will turn it back to you to see if there are any questions.
Great. Yeah. Thank you. Really thought-provoking discussion, Kelly. Thank you so much.
Thank you.
Just out of curiosity, or maybe you could just address, this we'll just take the bull by the horns. You know, the access to that micro data, that continuous, for instance, ventilator data. I know at our site, we've had a company come and say, we will apply all of our AI information to that level of data at your facility if you put our software in place and we can
Mhm.
collect it. So could I ask you to just maybe reflect a little bit on how do you manage your administrative at Vanderbilt to allow that industry, if you will, or AI to leverage, because the strength really comes from that relationship.
Right. Thank you, Dr. Tucker. I think that is that might get back to our cost question that was asked earlier, which is very, very much reality based. We have to understand high reliability for access to data that is repeatable and scalable. And quite frankly, that is very expensive. We would look to the interoperability maturity model as a standard of practice. So in fact, those things can happen. There are folks in critical access facilities that have no interoperability, so no access to the data. So you look at timely, is that timely entered into the electronic health record to detect deterioration? Is it in fact being keyed in correctly? Or are they putting it potentially on the wrong patient? So there are many paths here that we should consider around interoperability. And that's why I really appreciate the opportunity to speak to it today, because I don't want to think that folks that, not understand that this is not without effort. There is no standards body right now that can be compared to the UL labs, to the SWIFT banking network in healthcare. Healthcare is the last industry to adopt a national standard. Now, we do have standards, but we do not have a common infrastructure, such as a trusted platform that could then allow for everyone to be on the same page and have innovation to occur on top of that. Every other industry has that. Like I said, cable industry does, UL labs, healthcare lacks that. And that is a policy issue.
Yeah, thank you for that great discussion. Um, we're going to move on to Dr. Bunge's presentation, AI Conversational Agents for Mental Health. There are, by the way, a ton of great questions coming through the chat, and we will have a panelist discussion at the end as well. So just keep them flowing in and we'll get to all of them. Dr. Bunge?
Hello, thank you. Can you see my screen? Can you hear me? Yes, okay. So thank you so much for the invitation. I'm Eduardo Bunge from Palo Alto University, and I will talk about chatbots for mental health. So let me start by explaining what's a chatbot. Probably this is very basic, but it's a software that allows us to have conversations, right? And these conversations can be done in different formats. The ones that we are most familiar with today are the ones that are text to text, but you can also have ones through voice to text, or the ones that you can have with your Amazon Alexa or your Google Assistant. And what has been happening lately is that these chatbots, also known as conversational agents, are including a digital persona, right? So that's a new layer for the interaction. So basically, you talk to this persona answers talking to you, right? And you can see, right? So in the field of specifically mental health conversational agents, what we usually say is that you have traditional therapy where you talk to the client, to the patient, and the patient talk back to you, right? You have those dialogues. We had always been using self-help tools such as books first, and then we started doing guided internet interventions. And chatbots or conversational agents are something in the middle. We call it something like interactive self-help. Now, there are different types of chatbots, and I divided in two categories: rule-based chatbots and AI-based chatbots. But all of them use some level of AI, or at least natural language processing, right? So let's start explaining what are rule-based chatbots. Are these ones in which you have a set of rules that will guide the conversation, right? So you have a script where you write the possible answers to the questions that the user may give, right? So they usually respond to keywords or intents that are very specific to a specific task, but they cannot generate their own answers. You will see that this is different from what I will mention in a minute. And they are limited to the scope that you as a healthcare provider want to set, right? So if you want to talk about specifically a diagnosis about respiratory problems, or you want to have a conversation about visual problems, you can narrow the scope of that conversation, right? So they can only respond to specific queries. And when there's a match between what you need and the user needs, these chatbots work pretty good. But what usually happens is that they have many misunderstandings, and they typically respond with a generic apology that sometimes makes us feel a little bit annoyed, right? But one thing that's very important is that if you're not a very tech-savvy person, you can create this type of chatbots, and I will explain this at the very end of the presentation. The other type of chatbots are more complex. They require more natural language processing and machine learning. Probably the one that's more familiar to you is Alexa or the Google speaker. And as everyone mentioned today, OpenAI created a few years ago GPT-3, and today the most current version is ChatGPT, right? So these ones, you can benefit from these types of chatbots because they have APIs that allow you to control what the user asks to these type of chatbots. These require a level of technical that's a little bit more sophisticated, right? But the difference between these generative chatbot is that they can generate responses, right? It's not that you need to write all the possible responses that you will have in these conversations. You can integrate them with APIs. And of course, because this is new, you want to have some caveat on some caution on how to use it, right? But I would invite you all to ask these ChatGPT complex questions about your medical or health or educational field to see how they respond, because they are pretty accurate in most of the responses, not always, but we need to learn how to use it. In the market of mental health, we have many chatbots. I saw Dr. James showed a screen image of a Wobot. There's another one called Wysa. X2AI had one called Tess. There's also Uper. There's also Talk to Poppy that includes digital personas. And there's a social bot that's very known that's called Replica. But most of these chatbots have kind of their main thing is mostly rule-based, right? And what is interesting is that in the clinical field of mental health, we have seen that, at least for example, for depression in a recent meta-analysis, that there's a moderate effect of these interventions, right? And here you have like probably 11 studies, and the effect sizes of these interventions are in the moderate range. Usually in the short term, this is like a 3 months follow-up, right? So we still have a big challenge to before us to improve what we're doing, but there's promising effects of these chatbots. Now, something that's very interesting is that almost at the same time, a year ago, 2 years ago, there were 3 papers published about how people bond or establish therapeutic relationships with the bots. And this is something new from digital interventions. In the past, this didn't happen, right? So this gives a lot of power, but also a lot of responsibility. Now, if you are, let's say, nursing or education settings, why should I care about these chatbots? Basically, because all of us in our fields have conversations with our clients, right? And if you think that a chatbot can help you with some of these conversations, you may reduce the burden of your work. You may improve the outcomes if you can add your work and that chatbots all together, right? And you can expedite some processes. Why do I need to have always the same dialogues with my clients, with my patients, if I can have them answer these questions beforehand, right? And this is something that could be used for training the mental health or health professionals or the students, right? They can have the role of the student interacting with the bot, and you can have your students learning how to develop these bots. How can you do that? A very easy way to start is to connect in boxes with arrows. This is a tool called Chat Fuel to create chatbots. here you have, for example, how is the conference going? If someone says great, you can say, okay, glad to hear that. If someone says nah, you can say, can you tell me more? If someone says terrible, I hope that's not the case today, you can say, sorry to hear that. I'm sure it will get better. And you add this emoticon. Of course, this is a very simple example, but I want to make it very visual on how you can learn how to use this type of chatbots in your field. So that would be all. I leave it to some questions. Thank you.
Thank you, Eduardo. Great presentation. Quick question. What would be the most important difference between chatbots and, say, internet sites or apps when you're dealing with health or educational information?
I think I should have included that in the presentation, but the most important thing is that they can mimic conversations that humans are used to have with other humans, right? So now we're having conversations with something that's not a human. And that the effect that it's creating when the chatbots work well, right, is that humans start attributing human characteristics to the AI systems, right? So they anthropomorphize this AI. And when that happens, right, you usually have a more engagement level, a higher engagement level that typical digital interventions. People create these bonds and use them for longer than typical digital interventions. And the interaction is more natural. So if you think of learning process for students or psychoeducation or education for your clients, the learning process may be better. So I think that's kind of the biggest difference.
Great, thank you. That was super enlightening. Thank you again. Molly and Ariba, can you please turn on your cameras? So now's the time that we're going to hear some reflections from our learners. Molly Hobenzak is a registered nurse pursuing her PhD in nurse informatics. She's doing her thesis on incorporating social risk factors extracted using natural language processing into predictive models to prevent hospitalizations in home healthcare. Long title. Sounds like great work. After Molly, we will hear from Ariba Abid, who is an MD PhD candidate at Emory University. She first worked as a software engineer at Google before entering med school, and she co-founded MedAI, an organization that's working on developing AI curricula for medical trainees. So Molly, we're going to have you go first. Please unmute and provide some responses.
Thanks. And wow, I really learned so much today. And thank you so much for the opportunity to be here and to all the amazing presenters. Having experience as a nursing student and now a PhD student, I'd love to share a few ideas that stood out to me as a learner. First, I was really excited to hear Dr. James's example of sensor technology to prevent falls in the home. However, I think there's still somewhat of a lag in AI technology and education focused in the post-acute care setting, despite it really being a rich environment as more and more patients receive care in the home. As technology created for patients and clinicians in the home continues to grow, I really hope we also see this translated to increased AI policies in education specifically targeted at engaging and preparing patients and clinicians situated in post-acute care settings. I really also appreciated Dr. James highlighting the importance of interdisciplinary teams in the development of AI curriculum. I believe that each individual really brings such a unique and diverse perspective to the value of AI technology and how it can be integrated into their workflow. And one way I can see this being incorporated into health education is during interprofessional development events that we are often required to attend during our clinical studies. Specifically, this can be incorporated as a case study to encourage conversation around AI tool creation and implementation. From Dr. Aldrich's talk, I came away wishing that I had been exposed to the importance of interoperability earlier on in my education, and I really encourage health professional educators to consider how they can expose students to interoperability early on in their education and why this matters clinically. For me, the importance of interoperability became so clear after realizing that one prime example, for nurses at least, is the IV pump talking to the medication administration record and thinking about how this really supports the reduction of burden placed on nurses and helps to prevent medication errors that ultimately leads to better patient safety. Encouraging students to already begin to brainstorm all the ways interoperability impacts clinical practice early on in their education, I believe will help to prepare them to be leaders in recognizing and addressing interoperability challenges. And then finally, I was so excited to learn more about chatbots, which are still fairly new to me. Dr. Bunge really touched on the potential chatbots have to create meaningful connections. And I'm really curious to learn how chatbots can be used to support the mental health of students and clinicians as we really see this increase in burden and responsibilities placed on clinicians. It's clear with the rise of clinical simulations and with the recent release of ChatGPT that chatbots will play a role in health education, and I'm really excited to see how this continues to evolve. Thank you so much for the time, or for taking the time to hear my thoughts. Pass it on
Thanks,
to you.
Molly. Yeah, that's great. Ariba?
Hi, thank you so much for having me. It's been a pleasure being able to hear everyone speak. And I also would like to say that I really appreciate how interdisciplinary this panel has been. I think as a med student, it's kind of a rare opportunity to be with people from all over the all different kinds of healthcare providers. So I really appreciate this. So yeah, I'm a fourth year medical student at Emory University, and I've been really involved in AI education at Emory. So I really appreciated being able to hear Dr. James, your talk on AI education. While I've been at Emory, I've been involved with starting workshops that are now offered annually and electives that are offered to our second year and fourth year students. So I'm a big proponent of educating students about AI and starting early on. And what I found at Emory, at least, and with the other schools that we've shared our curriculum with, is that students are actually really excited about this and are asking for curricula on AI and machine learning, which has been really great to see. We've seen a very positive response for our students. So I'm excited for AI education to become part of the norm. And I also really liked what you said about integrating AI education into existing curricula, like evidence-based medicine. That's a pretty well-established part of the medical school curriculum, and incorporating AI into that. So I'm excited to see the AMA curriculum when it launches. And we've actually established a curriculum here at Emory, which I'd be happy to share a link to. We've shared it with other schools as well, and I would love to receive any feedback that people have on that. You also talked a little bit about sensors and AI-driven technology, for calculating risk for falls. I think that's super interesting, especially because we're going to see a lot more AI-driven, direct-to-consumer products, like Apple Watches that can detect EKGs and things. And I don't think we as med students right now are really taught how to incorporate that into clinical practice. What do we do with that data when patients bring it in? So I think that was really interesting, and I'm glad that you brought that up, because there's going to be a lot of questions about how to handle that data. How much can we trust the data that patients are bringing in from devices that we're not necessarily familiar with or trained to use? Dr. Tucker, I really appreciated you talking about the data to knowledge. I've been using AI actually in my own education as I've been studying for exams, just little things like asking ChatGPT to explain concepts to me that I don't understand, which has been an interesting experiment. I will say that I don't always trust the responses that ChatGPT gives me, but it has been interesting to see people using chatbots like ChatGPT for more and more diverse tasks. And it's cool to see people becoming more comfortable with talking to chatbots, which is something that I'll touch on again when I talk about the chatbots for therapy. Because I've seen things on the internet about people using AI for therapy chatbots, and it's interesting to read about the responses of patients when they find out that the conversations that they were having were generated by AI. The responses can be positive, they can also be negative. And there are lots of other spaces in medicine where chatbots could be really useful. Some of the speakers talked about burnout in medicine, which is an area that I'm really interested in. One of the things that I've heard providers talk about is the burden of responding to the messages that patients send them in their patient portals. It takes a lot of time to respond to those messages, and they're not always reimbursed for those in a way that provides a good incentive to put time into responding to those messages. So I think AI generated text could be really useful in responding to patients in that way, but we have to juggle the way that patients feel about talking to AI and whether that impacts the trust that they have in the care that we provide. Dr. Aldrich, she talked about interoperability, and I thought that was really interesting, especially because I think a lot of times we jump to AI to be a solution to technical problems, and sometimes it isn't that complicated. Sometimes we can solve problems that exist in medicine with something as simple as interoperability and establishing data standards. We don't always need machine learning to solve problems. Sometimes just getting devices to communicate with each other can go a long way in improving job satisfaction and reducing the amount of time that providers have to spend doing like mundane tasks and tedious data entry. So I'm glad that you brought that up. So yeah, Dr. Bungie, I thought it was really interesting that you shared that research on the therapeutic alliance between humans and chatbots. I hadn't seen that. So I'm glad that you brought that up. So yeah, thank you again for all of your talks. I learned a lot today, and I'll share that link to our curriculum again. So appreciate everybody's time.
Super. Malini Reap, such great comments from your perspectives. You've really added to what we're all learning today. Thank you again to all the presenters. I'm going to ask everyone to turn their cameras on that are on the panel or presented, so the speakers and planning committee. I'm going to ask the planning committee to briefly introduce yourself as you ask your question or make a statement. And Dr. Lomas, we're going to lead off with you.
Thanks, Carol. I'm Kim Lomas with the American Medical Association. I oversee our Innovations in Medical Education Consortium across the United States. I really appreciated all the speakers today. The comments were very insightful. Great start to our conversation for this workshop. I'm really curious about the relational aspects of this. Dr. James, you mentioned the notion of tool versus teaming. Dr. Bungie, you actually talked about add together, the clinician and the AI. And that's actually a term that the American Medical Association favors, is augmented intelligence. So I'm curious to hear from the panelists, what does the clinician need to bring? How do we perhaps need to be different in order to best interact with AI and ultimately get the best augmentation between the two capabilities?
I can start with that question, Dr. Lomas. Thank you for the question. So I've mentioned in the past, I view AI, and I know many have referred to AI or artificial intelligence as a tool, and then you're seeing language referring to it as a teammate in some cases. I actually saw an article or a report published by the National Academy of Medicine referring to artificial intelligence specifically in a military capacity as a teammate. And when you think about the characteristics of a teammate, like the Institution of Medicine published, I believe maybe in about 2012 or so, a document kind of outlining the characteristics of an effective team. And those include things like establishing goals and having clearly defined roles and mutual trust and communication and measurable outcomes. So that's where I see that that teaming with artificial intelligence being important. And I also see, I really appreciate the phrase or the term augmented intelligence. And I see all individuals involved with the care team augmenting one another because it allows them to bring their unique characteristics and or things that are uniquely them. For example, the patient, for example, is going to be an expert in their context and in who they are. Artificial intelligence, generally, it's developed with a specific goal or target or outcome in mind. And the clinician ultimately will serve to some extent as the mediator between patients and AI in some respects. But I also see the clinician as certain things are taken off of their plate, or because AI is performing specific tasks or it's been given a clearly defined role, a clinician can then perform their clearly defined role that perhaps AI is not quite as good at, like focusing on fostering and strengthening that patient-clinician relationship and improving things like communication working on things like empathy or being more empathic and so on. I just see a clinician being able to benefit from those uniquely human attributes because some of those things that they were previously doing, and in some cases, to be quite honest with you, did not want to do, AI can potentially take over those things and allow clinicians to be a bit more human in their interactions with their patients.
Super. Dr. Bungie, go ahead.
Yeah, thank you. So I'd like to start by saying that usually our attitudes towards technology influence what we think, right, about this augmentation intelligence, right? And I'm saying this because I've been talking about technology in mental health field for more than 10 years, and I always got pushbacks from the traditional therapists, right? Because they tend to see this as a threat. I actually said to the first person that talked about digital interventions when they were talking about this, is, hey, you will leave us without no jobs, right? The irony is that now I'm working in this field, but clinicians tend to have a higher resistance level than users on how to integrate these tools, right? That's one thing that we need to have clear. And that rather than seeing it as a threat, we clinicians, we need to start seeing it as an ally, someone that can help us do our job better. Now, it is very hard to see that happening if we're not exposed to it, right? So I think that from the training that we provide to the students, we need to start exposing them to this, right? I had a meeting with my lab students the other day saying, okay, I would like to create a bot to try to solve this problem. Should we do a rule base where we create the things, or should we use ChatGPT? Everyone said, let's we create the things because we have more control. Let's give it a try. And in 30 minutes, we started playing with ChatGPT, and the students were asking, let's keep on doing this, let's keep on doing this, because they saw the power of it, right? So I think that in order to have clients be able to establish a relationship with the bot, we are the ones that first need to be to trust the bot and to learn how to use it. Important, the bot has to match your needs, right? If it's a bot that has a lot of misunderstandings, as we were mentioning in the chat here, there's going to be more problems than solutions, right? So you want to work with the developers on creating a bot that has a personality, that clients can relate to that, right? That has an empathic way of responding to the queries, and that gives accurate responses. If you work on that, if you get involved on that, I'm sure that clinicians will start using it more and recommending it more. Mm-hmm. That would be my recommendation.
I think that's a good point. I think the more that we have knowledge, the more that we can add to the field and really make it work for our patients. It's not something to be feared. It's something that we should forward proactively have a role in. Dr. Shapiris, how about some perspectives from you?
I'm Carl Shapiris. I'm with Texas A&M University, San Antonio, and I'm a member of the planning committee. I want to thank all the panelists for such wonderful presentations. Dr. James suggested that AI will be a tool set that clinicians of the future will require. We've seen an incredible evolution of language-based generative AI like ChatGPT in just the past few months, and yet we're just dipping our toes into the possibilities of AI. While we're trying to catch up to the current technological innovations, I think we also have to consider what AI will look like in the future. So panelists, in your opinion, what are the most promising future developments in language-based generative AI models like ChatGPT, specifically for the health professions? And how do you envision their applications evolving over the next 5 years in order to supplement human work through health professional education?
Kelly?
Hi, yeah, I'm happy to start us off with that. Thank you for the question. Again, I think what we have to do is base ourselves in reality of what is the problem we're trying to solve. Have we actually looked at the fact of patient safety and continue to build upon previous work in the National Academy of Medicine dating back to 1999 to Err is Human? The fact is that entering into an episode of care is terribly unsafe, and our quality is poor for the United States. I challenge us to really look at the moral injury and dilemmas that our clinicians are facing as they're trying to possibly manage through their day without interoperability and without AI that can actually improve the outcomes in the care coordinations of what they're trying to do, which is serve humans. And so I go back to what is the problem that we're trying to solve? So I would suggest that in the model of systems mapping or digital twinning is what is the current state? What is the ideal state that we're trying to get to? And then how do we close that gap? And an example is even though we may say, so going back to my picture of the patient with all those medical devices around the bedside, are people even aware that if there is interoperability, that the data feeds into the electronic medical center record, that the nurse is actually has to go into the Epics and Cerners and revalidate that data for it to show for other clinicians and to be used in models. The fact that I don't believe that many people are even aware of the workflows to understand the current and future states is really where we needed to start. What are we trying to solve? So thank you for the question, and I'll defer to the other panelists.
Yeah. Any other thoughts on that specific question? If not, I'm going to ask any member of the planning committee to raise your virtual hand if you would want to ask a question or make some additional comments. We have 5 to 10 minutes left, and so we have a lot of time to open up maybe some new areas. Lisa, we'll start with you.
Thank you so much. My name is Lisa Howley. I am a senior director at the Association of American Medical Colleges and also on the planning committee, and delighted to be here and learning with and from all these great panelists today. There are a couple areas I wanted to ask about, and I'll just start with one because I don't want to take up too much of the time. But I know Eric Topol's work has already been mentioned, and there's another one that I wanted to mention, and that's Robert Wachter's work from 2015. You know, he published The Digital Doctor, and I just wanted to share a quote from that and then ask a question related to it. And he writes, "The combination of intelligent algorithms and automatic data entry will allow each healthcare professional to practice far closer to the top of her license. As less time is wasted on documenting the care, doctors and nurses will have more direct contact with patients and families, restoring much of the joy in practice that has been eroding like a coral reef with each new wave of non-clinical demands." And, you know, we haven't heard a lot about kind of the positive side, at least in regards to relieving our clinicians of some of the vast some refer to as non-clinical, although I think that's, you could argue it is clinical, you know, duties and demands and tasks. So interested in your thoughts about the opportunity here for clinicians to have time freed up to spend more time kind of really at the bedside with the patient and engaging in if you will, kind of more meaningful and joyful activities.
Great, thanks. There's any feedback on that? That would be great. Otherwise, Pam, why don't we head up to your comments?
Thank you, everybody, for your presentations. Those were wonderful. Lots of information. Kelly, I want to go back to your presentation on interoperability. Who do you see as the partners? How can we leverage to continue to make the advances within this area? And also you noted, I noted you said about design thinking, systems thinkers, and is that a competencies that we need to incorporate across all health professions, because we need to be thinking about that. Thank you. And Kelly, you don't just have to answer it, anybody can.
Thank you, Dr. Jeffrey. So yes, of course. And I think I could tie back into Lisa with the joy that we talk about, when I spoke about crossing the quality chasm, is that we have to look at where are the poor designs coming from, which I think leads into this system design thinking around, it's not that we need to throw the, baby out with the bathwater, but are we actually looking at current state and where are the opportunities of improvement here that we could simply do together, right? And so if we map that out to our ideal state, and it is not a repeatable process. So I could not go to a critical access hospital as well as a private funded facility. Those are completely different environments, and you have to do this process over and over again. I think the combination of teams between physicians and nurses and computer scientists and all of the folks around medical devices, the biomed people, this is a team effort. We have to quit speaking about the doctor's workflow or the nurse's workflow. We have to think about the human in the center who is our patient that we're serving, that we all dedicate our service to. And if we actually did that as a multidisciplinary approach, we would get much farther in improving the United States quality impact around patient safety and care. So those are my words, and thank you for the question.
Yeah, Kelly, thank you. The concept that we need to be patient workflow focused just really speaks to where we should be in healthcare versus pulling them at our leisure, so to speak. Dr. James, you had your hand up a little bit earlier. I think you were
Yes,
going to
I was.
comment.
Yeah, just in response to Dr. Howley's question, which I really appreciate. Bob is actually a mentor of mine, so I appreciate you bringing him into this conversation. But I just kind of think about, and as I've mentioned to others in the past, I think we have that example of the electronic health record, right? There were significant major promises associated with the electronic health record potentially improving clinicians' lives. And I think we're seeing a lot of that promise, and to some extent, to be quite honest with you, hype related to artificial intelligence and machine learning. But it's going to be important for us to reflect on and learn from some of those prior experiences related to the electronic health record. And I'm thinking specifically of the lack of clinicians and or potentially healthcare professionals or educators, even their involvement in the development and the deployment of that specific technology. And I think there's just a lot for us to learn from that example as we begin to implement these technologies into clinical workflow. And when we think about technology, specific the AI ML, I reflect on a day in clinic. For me, I do still practice clinical medicine, and I think about the benefits of simply having a scribe, an electronic scribe, and how that allows me to be a bit more engaged with the patient. And I'm not as concerned about some of those other workflow issues related to documentation that I have to be concerned about later. There are actually places right now that are using AI, as I'm sure many on this panel know, developing AI that will allow clinicians to not be as concerned about documentation, because there's going to be AI right there in the room to do those types of things for them, and even do things like billing and so on and so on. So I just bring that up because as we think about examples or opportunities for us to engage more effectively with our patients, because some of those tasks have been either taken off of our plate or we've been relieved to some extent by AI, I think it's going to allow us to be a bit more, again, human in our interactions with our patients.
I think that's a super great point, and I really appreciate both of you highlighting that. As your example of the electronic medical record, we just basically took a paper one, didn't really think about what the technology would allow, and just put it in a computer. And so even when you look at the interoperability within the different elements of the EHR, it's like you're still paging through papers. And really appreciate you as a clinician saying how this could be used so many times. And I know we're trying to get away from it. You're in a doctor's office and they're so busy typing in everything you say that if there was a way to get that in where eye contact could be made, and what I think we as humans are really good at, that empathy, that sense of connection, those patients that are lonely or don't get enough that understanding or that sense of being understanding. I think AI really could be leveraged for some of those tasks maybe that don't need that level and frees us up for our patients. We are nearing the end of this. And again, please continue to put any remaining questions in chat. We do have our 2-day workshop coming up week after next. And so this may be good questions that we can look and reflect on and hopefully provide some responses to between now and then. I want to thank the planning committee and all of the speakers for joining us today. And again, March 15th at 4 p.m. Eastern Time is when we will come back and explore some social, cultural, policy, legal, and regulatory considerations for learners of AI as a tool and as a content with health professions education. I know I learned a lot today, and really this is great speakers, great planning committee. Thank you.